stuck forever. But evidently it stuck with her. Maybe it'll stick with you guys too. Okay, let's talk about trough and peaks and go on a break. Trough and peak levels there at the bottom of the page. Trough means when the drug's at its what? Lowest, and peak is when the drug's at its highest. I call them tap levels because that tells you the order you do things in. What do you do first? T, draw your trough. A, administer your drug. P, draw your peak. So I teach students tap. Trough, administer, peak. So when is the peak drawn? After the administration. When is the trough drawn? Before the administration. Tap. T-A-P. Well, what's the reason for drawing tap levels? What we call narrow therapeutic window. Have you heard that term, narrow therapeutic window? And that means there's a very small difference between what works and what kills. So if a drug has a very small difference between what works and what kills, what will we draw on them? Taps. If they have a wide range, will we draw taps on them? No. So let me ask you this. What's the smallest dose of Lasix you ever gave or saw given? Lasix, furosemide, the diuretic. I've seen 10, 5 or 10. What's the most you've ever seen? 80, 120. So it goes anywhere from 10 to 120. Is that a narrow or a wide range?
Wide.
So would you draw troughs and peaks on Lasix? No. What about DIG? What's the lowest you've given of DIG? 0.125. What's the highest you give of DIG? 0.25. That's only 0.125 difference. That's pretty narrow. Would you do a peak and a trough on a DIG?
Yes.
Yes. So these mean old Mysins all have what drawn on them? Taps, because they have what? Narrow therapeutic windows. Now, I want you to understand, mean old Mysins are not the only class of drugs which have taps drawn, but they are a major class in which you draw taps. Therefore, that's why I'm talking about it here. Do you understand what I'm saying? This discussion of troughs and peaks could apply to a lot of other drugs besides these, but it definitely applies to these. So what boards will want to know is when you draw it, when you draw the trough, when you draw the peak. Good news. You don't even have to know what the drug is, because it depends on the route, which is great. This would be a fantastic question to get a drug you never heard of, because it doesn't matter. The route matters. So if they say, when would you draw the peak on a patient getting L-asparaginase IV push? What does not matter at all? L-asparaginase. What matters? IV push. Okay, so let's talk about this. Troughs. We'll fill in the trough column first. When do you draw a sublingual trough? A trough before. When do you draw the trough before you give a sublingual med? 30 minutes. 30. That's 30. I'm not saying 13. 30. 30. 30 minutes before the next dose. So if the med is being given at 10, sublingually, when do you draw your trough? 9:30. 30 minutes before that next dose. Let's talk about IV. We're going down the column. When do you draw a trough before an IV med? 30 minutes before the next dose. 30 minutes before the next dose. IM, when do you draw the trough? 30 minutes before the next dose. When do you draw a sub-Q? 30 minutes before the next dose. And lo and behold, what do you think the answer is for a PO med? 30 minutes before the next dose. So how hard is a trough question?
Not hard.
Not hard, because it doesn't matter what drug, and it doesn't matter what route. It's always 30 minutes. So how many trough questions do you want on your licensing exam?
Golf.
75. And LPNs, you want 85.
Yeah.
Because you're going to ace it. So don't sweat it. Great place. Other people are going to be sweating bullets and you're going to be laughing. Okay, the peak. Now, sorry to say, the peak is going to change. It's not going to be like the trough. But here again, it won't depend on the drug, it will depend on the route. Because I'm going to say something that is correct. Do not write this down, but this is true. The same drug given by two different routes at the same time will have two different peaks. I give PO morphine and IV push morphine at the same time. I'm going to have two peaks. It's the same drug. However, two different drugs given at the same time by the same route will peak together. Morphine and Phenergan, two different drugs given IV, same route, at the same time will peak together. So what determines the peak, the drug or the route? The route. So always pay attention to the route. So let's talk about it. When do you draw a sublingual peak? 5 to 10 minutes after the drug is dissolved. 5 to 10 minutes after the drug is dissolved. IV, 15 to 30 minutes after the drug is finished. Why did I say finished? Not when you what? Hang it. You don't start your clock when you hang it. You start your clock when it's finished. When the bag is empty. Then you go 15 to 30 minutes after that. What if they told you you were going to give... Sorry, didn't mean to slam on that. You're going to give 100 mil of a drug at 200 mil per hour. You understand that? You're going to give 100 mil at 200 an hour. So how long is that going to take to run in?
30 minutes.
30 minutes. Okay, you hang it at 10 a.m. So when's that going to finish? 10:30. When would you draw the peak?
10:45.
Well, they say A, 10:15.
No.
B, 10:30. C, 10:45. Yes. D, 11 o'clock. Yes. They do this all the time. Two right answers. Right, one's 15 after it's in, one's 30 after it's in. It's in the, isn't that the range?
Yeah.
Which one are you supposed to pick? 11. Whenever you get two in the same correct range, whenever you get two values in the range and they're both correct, play the Price is Right. Who wins on Price is Right? Highest without going over. So who's the highest here without going over? 11. And that's who wins all the time. For example, just to show you how this works in every case. Do you remember antidepressant meds? Antidepressant meds? How long does it take the typical antidepressant med to work? 2 to 4 weeks. 2 to 4 weeks. If boards told you that the client had been on it for 1 week already, got it? It's been on it for 1 week already, and they're saying, it didn't work and it didn't help and I feel horrible, what would you teach them? A, it may take another week to work. Is that true? Might it? Yes, that's the 2. And then B says it may take 3 more weeks to work. That's also true. So you got 2 right answers, 1 week and 3 weeks. Which one wins? 3 weeks, because you picked the highest without going over. When would a child be able to be potty trained during the night? 3 years or 5 years? Well, that's 3 to 5 years. Nighttime potty training for urine. So what would be your answer? 3 years or 5 years? 5, and you'd be right. Do you see what I'm saying? So always, whenever you're sitting there and you have 2 right answers, they both are correct numbers, pick the highest without going over. And that will always win. That's not just on this, but on everything. Okay, the IM. The IM is 30 to 60 minutes. You draw the IM peak 30 to 60 minutes after you give it. So if you were between 30 and 60, what would you pick? 60. See, they love to test this. You gave an IM Demerol for pain. When would you check them for relief? In 30 minutes or in an hour? Well, it's going to peak in 30 to 60. So it's either going to pick in 30 or 60. What would you say? 60. Yeah, because you want to give it enough time. You see what I'm saying? You could check them in 30, but you should at least check them within an hour. Okay, sub Q. Here I want you to write the word SEE. C, S-E-E. C diabetes lecture, which we'll talk about tomorrow. Because the only subcutaneous peaks they talk about are the insulins. And we'll just talk about it then, okay? They don't talk about terbutaline, sub-Q, or anything like that. And then in the PO box, put forget about it, because they don't test PO peaks. It's all too variable. All right, come back at 7:20, and we'll finish up for the day. Page 11, calcium channel blockers. Another top 10 group of drugs. But the good news about this one is there isn't a whole lot you need to know. You just have to know some basics about these heart drugs. Somewhere in the margin of this lecture, I want you to write the following. Calcium channel blockers are like Valium for your heart. Calcium channel blockers are like Valium for your heart. Now, why would I say that? I think that makes it easy for you to remember what they do. Because what does Valium do for your body and for you in general? What's it do? Calms you down. So what do you think calcium channel blockers do to the heart? They calm it down. So if you get a question about a calcium channel blocker, think, oh, that's going to calm my heart down. That would be just like giving my heart some Valium. Now, did I say it was Valium? No, it's not Valium. It has nothing to do with Valium. But it's like Valium for your heart. So if your heart is tachycardic, could it stand a little relaxant?
Yes.
So what class of drug could you give? Calcium channel blocker. If you're in shock, does your heart need to relax when you're in shock? No, you need it needs to get cooking here. So would you give a calcium channel blocker? No. If your heart was in heart block, would you give a calcium channel blocker? No. If your heart was having tachyarrhythmias, would you give a calcium channel blocker? Okay, so if you had a heart attack and you wanted to rest your heart, what would you give? Calcium channel blocker. So calcium channel blocker is given when you want to rest your heart. When your heart needs stimulated, please don't give a calcium channel blocker. That's not a good idea. So this is like Valium for your heart. Now, how do we say that really fancy? The way we say that fancy is the following. You see here where it says letter A, calcium channel blockers are negative inotropic, chronotropic, and dromotropic. When you see the fancy words negative inotropic, negative chronotropic, negative dromotropic, don't freak out. All that's saying is what? It's like Valium for your heart. So negative inotropes, negative chronotropes, negative dromotropes relax your heart. They calm it down. Now, the chart below shows you the difference between the positive inotrope, chronotrope, dromotropes and the negative inotrope, chronotrope, dromotropes. What do positive chronoinodromos do? Look down through there. What do? They strengthen, speed up, stimulate. So they are called what? Cardiac depressants or stimulants.
Stimulants.
And negatives are cardiac depressants. So a positive inochronodromotrope is a cardiac stimulant. A negative inochronodromo is a cardiac depressant. Do you see the difference? In that chart, which column should you highlight in this lecture because it applies to the calcium channel blockers?
Negative.
The last column. So circle and highlight the last column because that's where calcium channel blockers fit into the picture. They are negative inotropes. They weaken, slow down, and depress the heart. Letter B. When would we want to do that? What do they treat? Well, they treat A, AA, and AAA. The letter A is your friend here. A, AA, and AAA. Well, what does A stand for? Number one, they are antihypertensives. They are antihypertensives. How does that work? They relax your heart and blood vessels. And if you relax your heart and relax your blood vessels, what does your blood pressure do? It goes down. Does that make sense? If your blood pressure was high, would you take a Valium for your heart or a stimulant for your heart? If your blood pressure is high, would you want a Valium for your heart or a stimulant for your heart? Valium. And that would mean you'd use a calcium channel blocker. Do you see what I'm talking about? Okay, the second AA stands for anti-anginals. They are anti-angina drugs. Well, how does that work? It's going to relax your heart so it uses less oxygen, so there goes the angina away. It works by decreasing oxygen demand. It treats angina by decreasing oxygen demand because it relaxes the heart. What's the worst thing in the world for a person with angina? What's the worst thing that can happen to a person with angina? With their heart. What's the worst thing that can happen to their heart in a person with angina?
Speed up the heart.
Speed up. Speed up. And then it has problems. So we want to do what to the heart?
Slow it down.
AAA. Anti-atrial arrhythmia. Anti-atrial arrhythmia. So what does it treat? Will it treat ventricular tachycardia? No. Why? Because that's ventricular, and this only treats atrial. Will it treat atrial flutter?
Yes.
Atrial fibrillation?
Yes.
Premature ventricular contractions?
No.
Premature atrial contractions?
Yes.
Paroxysmal atrial tachycardia?
Yes.
Atrial bigeminy?
Yes.
Ventricular bigeminy?
No.
Huh. Hey, how I say that? I love medical transcriptionists that don't know what they're writing. We always have fun reading those charts on night shift. I remember one time I was working nights, I was tell you, that cracked me up. We were reading this guy's history and physical, and the doctor dictated it, and the transcriptionist wrote out the history and physical, and they make mistakes. She said that this guy had this guy has ventricular bigeminy. I go, whoa, that's cracking me up. That's funny. It's a lot of fun. Okay. So all you have to know what arrhythmias this treats is to know if it starts with what letter?
A.
And if it's an A, it's yes. And if it's a V, it's no. What? There's a trick. What about this one? Supraventricular tachycardia, SVT. Would calcium channel blockers treat SVT? Yes or no? How many say yes? You're correct. Yes. Why? What does supra mean? And what's above the ventricles?
Atrial.
Boom. So it's supraventricular is the only ventricular which is actually saying atrial. Does everybody get that? Otherwise, you're good to go. Because it treats A, AA, and AAA. Well, what are the side effects? H and H. The letter H is your friend here. Headache and hypotension. Headache and hypotension. Why hypotension? Because it relaxes the heart and the blood vessels. Why the headache? Because you get vasodilation in the brain, and that gives you like a migraine. By the way, headache is a great thing to check on a Selectol that apply. Because what do you have with low sodium? Headache. What do you have with a high sodium? Headache. What do you have with a high glucose? Headache. What do you have with a low glucose? Headache. What do you have with high blood pressure? Headache. What do you have with low blood pressure? Headache. You know, I mean, headache's pretty, I'm going with headache. Okay, names of calcium channel blockers. Names. Anything ending in dipene. Anything ending in dipene. Amlodipine, nifedipine, the dipenes. I always say you're dipping in the calcium channel. Not pene. Why not pene? Why do I not want you to memorize everything ending in pene? Because there are loads of drugs that end in pene that are not these. It has to be a dipene. Dipene. Dipene is your calcium channel blocker ending. And then there are two others you have to know by name. Verapamil and cardizem. Verapamil and cardizem. So the dipenes, verapamil and cardizem. Dipenes, verapamil, cardizem. Those are your calcium channel blockers. Which of those is continuous IV drip? Can be given to cardizem. So when you give a calcium channel blocker, now think about this. When you give a calcium channel blocker, what vital sign do you need to measure before you give it?
Blood pressure.
Why? What's the side effect?
Hypotension.
Hypotension. So you measure the blood pressure. What are your parameters? What are your guidelines? You get a blood pressure. So what? What are your guidelines? How are you going to use it?
It's below 60. Or no, wait a minute, I'm thinking the heart.
You're thinking pulse rate. You're thinking pulse rate. Over 60. Not that. Okay, which one? Yes. Hold the calcium channel blocker if the systolic, that's the top number, is under 100. Take the blood pressure, or measure, don't take it, measure it. Measure the blood pressure, and if the systolic is under 100, then you hold the calcium channel blocker. So what do you have to monitor continuously or fairly quickly, intermittently, while they're on a cardizem drip? The blood pressure. And there again, if it was 98/52, what would you do? What would you do with the drip? Slow it down, measure it again. So you titrate. Do you know what I mean by titrate? Change the IV rate to keep the blood pressure what? Systolic over 100. LPNs, they would say if somebody's on a cardizem drip, you notice all the following. Which one would you report to the RN? It's a systolic falling below 100. Same information, just ask from a different perspective. Okay, cardiac arrhythmias. The ones we're going to do for the rest of the night are short, so that as the day goes on, your brain gets more spaghetti-like, and I just want to keep it faster so you don't get no big long ones in the middle of the night. Cardiac arrhythmias. Knowing how to interpret rhythm strips. Now, turn to page 13, the next page down. Next page. Do you see at the bottom of the page there are 4 rhythm strip tracings? These are the 4 you must know by sight. You have to know these by sight. The first one is normal sinus rhythm. How do you know it is normal sinus rhythm? There's a P wave, a QRS, and a T wave for every single complex. There's a P wave before every QRS, and every QRS is followed by a T wave. But what else tells you it is normal sinus rhythm? Do you see the peaks of the P waves? How equally distant they are from one another? That tells you you're not dealing with something called a sinus arrhythmia. So that is normal sinus rhythm because there's a P for every QRS and the QRS complexes are evenly spaced. When you see that, that's normal sinus rhythm. It doesn't really matter if they go up or down. Do you know what I mean? You could have a P wave going up, QRS going down. That's okay. That's still normal sinus. The second one is VFib, ventricular fibrillation. It is a chaotic, squiggly line. The third one, it looks like a 1970s wallpaper border. That's VTAC, ventricular tachycardia. It's got those sharp peaks and jags. Is there a pattern? Yeah. Is there a pattern with ventricular fibrillation? No, there's no pattern with VFib. There is a pattern with VTAC. And the last one is called what? Asystole. Please don't miss that one. I honestly don't miss it. I mean, you're going to go down and down. Big time. Crash and burn time. Okay, let's go back to page 12 now. Now, I just want to hit those right out the gate. Now, could they show you Wolff-Parkinson-White syndrome? Yeah. But why do I not teach you that?
You don't need to know it.
You don't need to know it. But you said, but Mark, you said if they show it to me, don't I need to know it? What's the answer? No. What do you need to know? You need to know the answers to the questions that everybody else knows. And everybody else knows what asystole looks like. And everybody else knows what VFib looks like. And everybody else knows what VTAC looks like. And everybody else knows what normal sinus looks like. Nobody else knows what Wolff-Parkinson-White syndrome looks like. So if you miss that, it doesn't hurt you. You understand these questions are all given degrees of difficulty? So do you have to get every question right? No. What questions do you have to get right? The ones that everybody knows. The easy questions. You can miss every single hard question on the boards and pass with flying colors. Do you understand what I'm saying? So what I want, why do I teach you what I teach you? I want to teach you the stuff that everybody knows. So that you real quickly get correct the answers to the questions that everybody else knows, so that real quickly you get to what kind of questions? Hard ones that no one knows. Now you're going to feel how? Horrible, because you don't know any of this stuff. But that's good. Do you know what I'm saying? My goal is to, as fast as I can, get you to the hard questions. The questions that nobody else knows, including you. So that you feel really stupid. Do you see what I'm saying? I want halfway through this test, I want you to be going, what? What is that drug? What disease is that? What are you talking about? Who's that? What's this? You know. Because you understand, you don't have to know everything. You just have to know what everybody else knows. What a little less than average. And so we're not going to, that's what kills me about a lot of these review books. A lot of these review books have all these rhythm strips in it, which is ridiculous. And these people have to memorize these rhythm strips, like 50 of them. And only 4 of them really are going to hurt you if you don't know. So why do those other books put those rhythm strips in their review? Why do they put them in there? Because they what? Heard that they're on there. They heard that they're on there. And so they what? They heard that something's on there, so what do immediately in their book? They throw it in, and their books get what? Thicker and thicker and thicker. My books are what? Thin. Let's focus on the stuff you need to know, and not the crazy stuff. I always say there's 3 levels of nursing knowledge. Stuff you need to know, stuff that's nice to know, and stuff that's nuts to know. And most of nursing books are made up of nuts to know.
Yes.
Have you ever asked the teacher, just tell me what I need to know? And they say, well, read the book and the notes. Well, that's helpful.